Good day, everyone. This is Group D4, and today we'll be discussing intranatal complications focusing on inlet contraction, outlet contraction, placenta subcentoriata, placenta circumvallata, placenta accreta, battledore placenta, vasa previa, two-vessel cord, and unusual cord length. The following are the group members: Ms. Rose and Carla D. Bispo, Mr. Ronald Ko Jr., Miss Alisa Marie T. Dinoy, Miss Regine Catherine Aldomapias, Miss Precious Ann G. Layson, Miss Zia Princess Angela Haven V. Longakit, Miss Erica China M. Paco, Mr. G.V. B. Roma, Miss Alia Mai M. Rosal, Miss Nicole Ariel P. Tabuco, and Miss Alia Marie B. Villafuerte. To open, we'll first discuss inlet contraction. So what may we think about when we discuss inlet contraction? Inlet contraction is defined as the narrowing of the anterior-posterior diameter of the pelvis to less than 11 centimeters, or of the transverse diameter to 12 centimeters or less, interfering with the normal mechanism of labor. So when both diameters are contracted, the incidence of dystocia is much greater than when only one diameter is contracted. Dystocia is defined as difficult or obstructed labor. To first understand the etiology or cause of inlet contraction, we must first understand that there are multiple factors that affect the size and shape of the pelvis, such as developmental factor, nutritional factor, racial factor, sexual factor, metabolic factor, and health factor. Inlet contraction can be inherited or congenital. Malnutrition can result in a small pelvis. And in a study done by Glenning and Bond, it was observed that there was a higher incidence of a contracted pelvis among Southern Europeans than in Anglo-Saxons. For sexual factor, an excessive androgen may produce an android pelvis. Rickets and osteomalacia, or a marked softening of the bones, are likely causes of pelvic contraction. Health factors such as trauma, diseases, or tumors of the bony pelvis, legs, or spines can also cause pelvic contraction. Related to problems with the narrowing of the passage, which can cause CPD or cephalopelvic disproportion, or a disproportion between the size of the fetal head and the pelvic diameters, which then results in failure to progress in labor. Although many factors surround this condition, it is usually caused by rickets, or a metabolic factor, in early life or by an inherited small pelvis. So rickets is caused by a lack of calcium and is therefore rare in developed countries, but can occur among immigrants who were raised where milk supplies were not plentiful. For signs and symptoms of inlet contraction, the following may be observed. If the fetal head engages during the 36th to 38th week of pregnancy, then the pelvic inlet is adequate. If there is no engagement in primigravidis, however, then either a fetal abnormality or a pelvic abnormality should be suspected. A pendulous abdomen is suspicious of inlet contraction, especially in primigravidae. So a pendulous abdomen looks like this picture on the left, with the abdomen hanging out. And in women with a contracted pelvis, face and shoulder presentation, such as this picture on the right, are encountered 3 times more frequently. Incidence of cord prolapse is increased, as well as increased occurrences of a slowed cervical dilatation. In the face presentation, the chin is not tucked, inhibiting the engagement of the head and slowing down the labor process. There are numerous management techniques that one can do in order to prevent or reduce the risks of a difficult labor and deliver the neonate safely and healthy. For nursing management, every primigravida should have pelvic measurements taken and recorded before week 24 of pregnancy so that based on these measurements and the assumption that features will be of average size, a birth decision can be made. Obtain previous obstetric history and perform a physical examination in order to determine the stature and stigma and ascertain the degree of disproportion. Perform an abdominal examination to determine if there is a non-engagement of the head in the last 3 to 4 weeks in primigravida, as this is usually indicative of cephalopelvic disproportion aside from inlet contraction. This also helps to determine a pendulous abdomen or hanging abdomen in primigravida and determine for any malpresentations. By way of inspection, a pendulous abdomen is suspicious of inlet contraction, especially in primigravidae. Perform a clinic pelvimetry by bimanual examination or by imaging studies such as radiopelvimetry, computed tomography or CT scan, or by magnetic resonance imaging or MRI. Pelvimetry helps to assess the size of a woman's pelvis, aiming to predict whether she will be able to give birth vaginally or not. Moving on, for medical management in moderate to severe degrees of inlet contraction, any of the following may be performed: induction of labor, trial labor, or cesarean section. Besides the case of a multigravida woman who has to have labor induction approximately 2 to 3 weeks prior to the estimated date of confinement with a history of a difficult labor, labor induction should only be performed when the fetus is in a longitudinal lie, the cervix is ripe or ready for birth, the presenting part is a fetal head or vertex and is engaged, there is no CPD, and the fetus is estimated to be mature by date or over 39 weeks. Trial labor is the conduction of spontaneous labor in a moderate degree of cephalopelvic disproportion in an institution under supervision with watchful expectancy, hoping for a vaginal delivery. Contraindications of trial labor include associated mid-pelvic and outlet contraction, presence of complicating factors like elderly primigravida, malpresentation, post-maturity, post-cesarean pregnancy, preeclampsia, medical disorders like heart disease, tuberculosis, and etc., and where facilities for cesarean section is not available round the clock. For pharmacologic management, when labor induction has been considered, oxytocin is used to stimulate labor. The labor should be ideally spontaneous in onset, but in cases where the labor fails to start even on due date, induction of labor may be done. Augmentation of labor with amniotomy and oxytocin infusion should be done only when the cervix has dilated to 3 centimeters or approximately 2 fingers. For surgical management, elective cesarean section is advocated when the obstetrical conjugate is below 9 centimeters, especially with premature rupture of membranes and moderate to severe degrees of inlet contraction. Seen here are pictures of a normal pelvis versus a contracted pelvis due to rickets. Next is a nursing care plan on inlet contraction. The identified need, problems, or cues is a physiologic overload, which is dysfunctional labor. Objective cues include a pendulous abdomen, the baby is in breech presentation, the cervical dilatation remains at less than 4 centimeters after 8 hours, there is a failure of baby to descend, and the mother appears fatigued. For subjective cues, the patient stated, "Gikapoy na kog utong, sakit na kaayo akong batang." For nursing diagnosis, we have a risk for fetal injury related to abnormalities in the maternal pelvis. The scientific basis for this is that there are several labor abnormalities that may interfere with the orderly progression to spontaneous delivery. Generally, these are referred to as dystocia. Dystocia literally means difficult labor and is characterized by an abnormally slow labor progress. It arises from 4 distinct abnormalities that may exist singly or in a combination. First, Explosive forces may be abnormal. For example, uterine contractions may be insufficiently strong or inappropriately coordinated to efface and dilate the cervix. Uterine dysfunction. Also, there may be inadequate voluntary maternal muscle effort during the second stage of labor. Second, fetal abnormalities of presentation, position, or development may slow labor. Also, abnormalities of the maternal bony pelvis may create a contracted pelvis. And last, soft tissue abnormalities of the reproductive tract may form an obstacle to fetal descent. The pelvis can cause abnormal labor because its contours may be too small or narrow to allow passage of the infant. Both the passenger and the pelvis cause abnormal labor by a mechanical obstruction referred to as mechanical dystocia. For objectives of care, we have both general and specific objectives. So for general objective, after 12 hours of holistic nursing care, the client will be able to achieve a good labor pattern and neonate will be delivered without complications. For specific objectives, after 8 hours of nursing intervention, the patient will, number 1, participate in interventions to improve labor pattern and/or reduce identified risk factors. And second, display fetal heart rate within normal limits with good variability and no decelerations noted. For nursing interventions, we provided independent, dependent, and collaborative nursing interventions. So for independent, before applying a fetal monitor or administering oxytocin, encourage the patient to void and palpate the bladder every 2 hours for distension. The rationale is that a full bladder causes discomfort, especially when equipment is placed on the patient's abdomen. Next, monitor intake and output, and measure urine-specific gravity. The rationale being, decreased output with increased specific gravity may indicate urine retention, which may impede fetal descent. Next, assess fetal heart rate manually or electronically. Note variability, periodic changes, and baseline rate. This is done to ensure adequate assessment of fetal heart rate and contraction pattern. Next, explain oxytocin protocol to the patient and her support person. Describe how oxytocin-induced contractions may peak more quickly and last longer than spontaneous contractions. This is done to allay apprehension and encourage patient participation. Next, monitor fetal descent in the birth canal in relation to ischial spines. Descent that is less than 1 cm per hour for a primipara or less than 2 cm per hour for a multipara may indicate CPD or malposition. Next, evaluate the current level of fatigue as well as activity and rest prior to onset of labor. This is done so that excess maternal exhaustion contributes to secondary dysfunction or may be the result of prolonged labor or false labor. Next, note effacement, fetal position, and fetal presentation. These indicators of labor progress may identify a contributing cause of prolonged labor. For example, a breech presentation is not as effective a wedge for cervical dilatation as in vertex presentation. And then observe for visible cord prolapse when membranes rupture and occult cord prolapse as indicated by variable decelerations on monitor strip, especially if the fetus is in breech presentation. As cord prolapse is more likely to occur in breech presentation because the presenting part is not firmly engaged, nor is it totally blocking the os as in vertex presentation. For dependent interventions, administer antibiotic to client as indicated. This prevents or treats ascending infection and will protect fetus as well. For collaborative interventions, prepare for cesarean delivery of breech presentation if fetus fails to descend and labor progress ceases or CPD is identified. The rationale being, Vaginal delivery of an infant in breech position is associated with injury to the fetal spinal column, brachial plexus clavicle, and brain structures, increasing neonatal mortality and morbidity. Risk of hypoxia caused by prolonged vagal stimulation with head compression and trauma such as hemorrhage can be alleviated or prevented if CPD is identified and cervical intervention follows immediately.
Hi, I'm Elia Villafuerte and I will be talking about outlet contraction. CPD, or cephalopelvic disproportion at the outlet, is defined as one where the biparietal suboccipitobregmatic plane fails to pass through the bispinous and anteroposterior plane of the outlet. For the etiology or cause of outlet contraction, first it usually occurs on short women. Next is nutritional and environmental defects. Next is developmental defects like Nigel's pelvis, Robert's pelvis, high or low assimilation pelvis. Next is diseases or injuries affecting bones of the pelvis like fracture, tumors, and TB arthritis. Also, diseases or injuries of the spine like kyphosis, scoliosis, spondylolisthesis, and coccygeal deformity. Lastly are diseases or injuries affecting the lower limbs like poliomyelitis and hip joint disease. The signs and symptoms of outlet contraction are arresting of the head in the pelvic inlet, positive Vasten sign, signs of urinary bladder compression, edema of the cervix and vaginal walls, production of fistulas, pushing occurs in location of fetal head in inlet, the pelvic capacity is diminished from the inlet to the outlet, subpubic angle is acute, convergent side walls, and bituberous diameter is 8 cm or less. Let us now move on to the management. So first is the nursing management. So as a nurse, we need to continuously support our client physically and emotionally. Next is evaluate patient to assess level of fatigue. Lastly, if the mother is doing well, encourage adequate fluid intake and small frequent meals. Next is the medical management. So first is epidural anesthesia and the trial of labor. Trial of labor is a clinical test for the factors that cannot be determined before the start of labor. Next is the pharmacologic management. So if rest is needed, a sleep medication zolpidem 5 to 10 milligrams orally may be taken at home, or admit patient for morphine sedation with 15 to 20 milligrams. Lastly is the surgical management. So first is forceps delivery. Next is vaginal delivery for minor disproportion or minor degree of contracted pelvis. Next is the cesarean section for moderate disproportion or moderate degree of contracted pelvis if trial of labor is failed, and marked disproportion or severe or extreme degree of contracted pelvis. Here are some relevant pictures for outlet contraction. Let us now move on to one nursing care plan for outlet contraction. For the needs, problems, and cues, physiologic deficit, risk for fetal injury. For the objective cues, it's the positive Vasten sign, production of fistulas, and 8 cm interischial tuberous diameter. For the subjective cues, sakit kaayo akong batang nga mura kog kalibangon as verbalized by client. For the nursing diagnosis, risk for fetal injury as evidenced by 8 cm interischial tuberous diameter. For the scientific basis, contracted outlet is usually defined as an interischial tuberous diameter of 8 cm or less. The pelvic outlet may be roughly likened to two triangles with the interischial tuberous diameter constituting the base of both. Floberg and Associates reported that outlet contractions were found in almost 1% of more than 1,400 unselected nulliparas with term pregnancies. A contracted outlet may cause dystocia not so much by itself but by an often associated mid-pelvic contraction. Next is objectives of care. For the general objectives, after 1 week of nurse-client interaction, the client will be able to initiate behaviors to reduce risk of fetal injury as appropriate. For the specific objectives, after 8 hours of nurse-patient interaction, the patient will be able to first reduce risk of fetal injury. Next is verbalized reduction of pain. And lastly, fetus will be free of preventable trauma or other complications. Next is the nursing interventions, measures to reduce the risk of fetal injury. For the independent nursing intervention, first is assess fetal position, station, and presentation. The rationale of this is that malpresentation such as face mentum or brow may prolong labor and increase the likelihood that cesarean delivery will be necessary. Because lack of neck flexion increases the diameter of the fetal head as it passes through the pelvic outlet. Breech presentation usually necessitates surgical intervention owing to the high risk of spinal cord injuries resulting from hyperextension of the fetal head during vaginal delivery. Next is maintain record of events. Accurate documentation provides information about neonate or client status and postpartum needs. Lastly, for independent nursing intervention is preparing for surgical intervention if indicated. This may be necessary in cases of CPD, persistent OP position, or deep transverse arrest of the head with prolonged stage 2 labor or fetal distress, or with breech or shoulder presentation. Fetus with anencephaly may not dilate maternal tissues effectively and may therefore require surgical intervention. Next is the dependent nursing intervention. So assist with vertex rotation from OP to OA by Scanzoni maneuver. Manual or vacuum rotation from OP to OA is possible if no CPD exists. Double application of forceps to vertex may increase risk for fetal injury, yet OA position is preferred position for delivery. Next is assist with vaginal delivery when the fetus is in posterior position. Posterior position increases possibility of fetal trauma caused by neck injuries. Last but not the least is the collaborative nursing intervention. So for this, complementary therapies as indicated like acupressure and acupuncture. Some clients and healthcare providers may prefer a trial of alternative therapies to mediate pain before pursuing invasive techniques. And that's it for outlet contraction. Let us now move on to the next complication.
Good day everyone, this is Erica China Paco presenting to you placenta succensurata. This particular disease is a morphological abnormality of the placenta where one or more of the lobes are present outside the placental body. These can have different sizes and are connected by blood vessels to the main placenta. Aside from that, the accessory lobe develops from the chorionic villi that did not involute from the main chorion. Now, for its etiology or cause, they appear to be associated with increasing maternal age and are more common in women who received in vitro fertilization. It is formed by non-involution of the chorionic villi, which means that some of the chorionic villi fail to disappear, resulting in the formation of an extra lobe of the placenta. As for its signs and symptoms, there are no specific signs and symptoms associated with an accessory lobe of placenta. Usually they are found during a routine ultrasound examination performed during pregnancy. Nursing diagnosis is risk for fetal injury related to placental abnormalities. Now, for the management, let us first start with the nursing management. Monitor rate of uterine involution and nature, as well as the amount of lochial discharge. Second, observe for signs of fever, chills, body malaise, anorexia, pelvic pain, or uterine tenderness. And also, check the episiotomy site and abdominal wound for signs of edema, erythema, separation of wound edges, and purulent drainage. And lastly, we have here, Check for other possible sources of infection, such as urinary tract infection. As for the medical management, obtain a gram stain or culture and sensitivity if lochia is not noted to have an odoriferous smell or a purulent wound discharge is observed. Also, obtain an antenatal ultrasound since it is important to establish the location of any connecting vessels and, in particular, to look for any vascular connection crossing the internal OS. Next would be the pharmacological management. For this one, administer medication as prescribed. Next would be the surgical management. So if you deliver via cesarean, your doctor will physically remove the placenta from your uterus before closing up the incision in the uterus and your stomach. You'll be advised to have an epidural or spinal anesthetic when the placenta is removed. With either, you'll be awake but pain-free. Next up is the nursing care plan. Starting with the cues, we have here physiologic overload, risk for fetal injury. Objective cues, we have here pulse, which is 90 beats per minute, blood pressure 120/80, and then the temperature is 37 degrees Celsius. As for the subjective cues, as verbalized by the client, sige sakit ako lower abdomen o ako apong likod. Next is the nursing diagnosis. Risk for fetal injury related to placental abnormalities. And then we have here scientific basis. Vessels connecting the main placenta with the succensurate lobe may rupture during labor and lead to fetal demise. In addition, retained placenta may lead to primary as well as secondary postpartum hemorrhage. Later on, it may lead to uterine sepsis and subinvolution. Also, there is a mild risk of placental abruption as well. As for the objectives of care, we have here the general objectives. After 24 hours of holistic nursing care, the client shall receive proper intranatal care and ensure a healthy pregnancy and uncomplicated delivery. As for the specific objectives, verbalize and differentiate causative factors and plausible risk associated with the complication. And then we also have here reduced risk of fetal and maternal injury. Next, we have here the nursing interventions. Starting with the independent. First, allow client the opportunity to ask questions and verbalize misconceptions regarding the complication. Second, measure a 24-hour intake and output. Also observe for signs of voiding difficulty. And then we have here dependent. Administer medication as prescribed. Contact the attending physician as appropriate. As for the collaborative, first would be refer to a gynecologist as appropriate. And second, assist with procedures as indicated, such as manual separation and removal of placenta. Moving on with the rationale, let's first start with the independent. First, provides for clarification of misconceptions, identification of problems, and opportunity to begin to develop coping skills. Second, this will help in determining the fluid loss. A urine output of 30 to 50 ml per hour or more indicates an adequate circulating volume. Next, for the dependent, to further ease discomfort and to alleviate complication. Also, it may help in addressing some issues regarding the client's needs. As for the collaborative, accurate and proper referral helps the client if further treatment is necessary. 2. Hemorrhage stops once placental fragments are removed and uterus contracts, closing venous sinuses.
Placenta circumvallate. It will be reported by Dino Eliza Marti and Layson Precious Angie. For the definition, circumvallate placenta is a placental anomaly in which the transition from membranous to villous chorion occurs away from the placental edge, resulting in a central depression that is surrounded by a thickened, raised, implicated gray-white ring on the fetal surface of the placenta, and a chorionic plate that is smaller than the placental basal plate. For the etiology, circumvallate placenta is an abnormality in the shape of the placenta. It can result in a lack of nutrients for the fetus. In circumvallate placenta, the chorionic plate, which is the part of the placenta that's on the fetal side, is too small. It causes the membranes to double back on the fetal side and around the edges. The condition can be detected by ultrasound and is usually diagnosed around the week 20 of pregnancy. However, diagnosis during pregnancy can be difficult, and the condition is often not detected until the placenta is examined following delivery. Circumvallate placenta is a variation of placenta development. It is said that researchers don't know precisely what causes circumvallate placenta. For the signs and symptoms, clinical symptoms, vaginal bleeding. A circumvallate placenta leads to a higher chance of persistent vaginal bleeding during the first trimester. There is also premature rupture of membranes, so PROM. PROM occurs when the amniotic sac breaks before the onset of labor, and it can affect up to 8% of pregnancies. If the rupture happens in the first 37 weeks of pregnancy, doctors refer to it as preterm PROM or PPROM. Inhibited fetal growth. A fetus may grow more slowly in a woman with a circumvallate placenta. Oligohydramnios is also observed, and it refers to a low level of amniotic fluid during pregnancy. Ultrasonographic findings. Thickened placenta. After delivery, a circumvallate placenta has a thick ring of membranes on its fetal surface. Hematoma at the placental margin is also observed because hematoma reportedly forms in the circumvallate placenta margin, causing ascending infection, progressing to chorioamnionitis. Chorioamnionitis is a bacterial infection that occurs before or during labor. It refers to the membrane surrounding the fetus, the chorion, which is the outer membrane, and the amnion, the fluid-filled sac.
And now for the management. We'll start with the nursing management. Nurses, or us future nurses, we hold a very vital role in this situation. This is because our assessment will serve as a baseline data for all healthcare providers in plotting the care plan for the patient. So we have to assess for signs of shock since there is excessive bleeding, especially when this occurs. We also have to assess the bleeding if it's external or internal. We have to monitor contractions if separation occurs during labor. We have to obtain baseline vital signs for comparison. We have to assess for the time the bleeding began, the amount and kind of bleeding, the interventions done when bleeding occurred if it started before admission. And lastly, we also have to assess for the quality of pain. 3 medical management will be given if bleeding starts. First is the intravenous therapy. The physician would order a large gauge catheter to replace the fluid losses. This will later on be discussed on our nursing care plan. Another is oxygen inhalation. This will be delivered via face mask. This would prevent fetal anoxia. And lastly is the fibrinogen determination. This test would be taken several times before birth to detect DIC or disseminated intravascular coagulation. So what is DIC? This is a serious disorder in which the proteins that control blood clotting became overactive. Now for the pharmacologic management, the following pharmaceutical agents can be given as prescribed. First is the analgesics. Analgesics like morphine if there is pain, tissue damage, or irritability. Another is corticosteroid like hydrocortisone or dexamethasone. Their mode of action is controversial. They may decrease peripheral resistance and potentiate cardiac response, so it improves tissue perfusion. So tissue perfusion, we could think of it as the delivery of blood to a capillary bed in tissue. Another is vasopressors. This is to increase the blood pressure to maintain renal perfusion. The last management is the surgical management. So, if it reached the stage wherein it may endanger the life of both mother and the fetus, then surgical management is put into action. One is cesarean delivery. If birth is imminent, it is safest to deliver the baby via cesarean. Another is hysterectomy. The worst outcome would be for the woman to develop DIC and to prevent exsanguination or excessive blood loss that may lead to death. Hence, hysterectomy must be performed. So here are pictures of circumvallate placenta. So as mentioned a while ago, circumvallate placenta happens when the chorionic plate, which is the part of the placenta that's on the fetal side, is too small. This causes the membranes to double back on the fetal side and around the edges. So this is how a normal placenta looks, and this is how a placenta circumvallate looks. Now for the nursing care plan, we'll start with the needs, problems, and cues. This is a physiologic deficit, deficient fluid volume. The objective cues are 1. Placental abruption, or this is the separation of the placenta from the inner wall of the uterus before birth. Persistent vaginal bleeding, reduced amniotic fluid, inhibited fetal growth. Vital signs are as follows: low blood pressure of 80/50 mm mercury, low body temperature of 36.2 degrees Celsius, pulse rate of 102 beats per minute, and respiratory rate of 20 breaths per minute. The subjective cues: the patient verbalizes, "Lipong na jud kay akong pamati ron," and she also stated, "Murag bugnaw na jud kay ko." The nursing diagnosis that we came up is the risk for deficient fluid volume related to bleeding during pregnancy, as evidenced by placental abruption. For the scientific basis that will support our nursing diagnosis, circumvallate placenta is an abnormality in the shape of the placenta. Hence, we mentioned in our objective cues that there is reduced amniotic fluid and inhibited fetal growth. This is because of the picture shown above. Placenta abruption is one of the complications of circumvallate placenta that can cause life-threatening problems for both mother and baby. For the mother, placental abruption can lead to shock due to blood loss, blood clotting problems, the need for a blood transfusion, failure of the kidneys or other organs resulting from blood loss, and rarely, the need for hysterectomy if uterine bleeding can't be controlled. For the baby, placental abruption can lead to premature birth. Now, for the objectives of care, we'll start with the general objective. After 12 hours of client-student-nurse interaction, sufficient fluid volume will be maintained. To achieve our general objectives, we have to achieve first our specific objectives, which is after 8 hours of nurse-patient interaction, client will display vital signs within acceptable limits. A blood pressure that is maintained at above 100/60 mm mercury, a pulse rate that is below 100 beats per minute, and a fetal heart rate that is maintained at 100 to 160 beats per minute, and a urine output that is greater than 30 ml per hour. To achieve our objectives, we have these nursing interventions. First is to begin intravenous fluids such as lactated ringers with a 16 or 18 gauge angiocath. Lactated ringers is a sterile solution for fluid and electrolyte replenishment. Hence, this replaces intravascular fluid volume. Intravenous line is established if blood replacement will be needed. Administer oxygen at 6 to 10 liters per minute via face mask. This provides adequate fetal oxygenation despite lowered maternal circulating blood volume. As mentioned, this is to prevent fetal anoxia. Another is to order type and cross-match of 2 units whole blood. This allows for restoring circulating maternal blood volume if needed. We also have to measure maternal blood loss by weighing perineal pads and save any tissue that has passed. This provides objective evidence of amount bleeding. Next is to monitor vital signs and fetal heart rate. This provides baseline data on maternal response to blood loss and to check for fetal status. The second to the last intervention is to withhold oral fluid. This is to anticipate the need for emergency surgery. It is important to empty stomach before any surgery to prevent nausea and to keep food or any fluid from getting into the lungs. And the last intervention is to keep a positive environment and provide emotional support to the pregnant woman. This is to assist problem solving, which is lessened by poor self-esteem.